Thank you. So in this talk, in order to kind of make it a little more unique and use the time that I have, I'm going to focus on muscle pathology that would commonly affect the lower extremity. So I'm going to briefly talk about the normal ultrasound appearance of muscle, and then I'm going to talk about processes that involve trauma, masses, and diffuse processes of the muscle. So what I teach my trainees and my sonographers is that when they're looking at what they call soft tissue, as we're seeing here in this cine clip, it's important to try to differentiate the layers of what you're looking at. That way, if you do see some sort of pathology, you can try to localize where it is. So we're looking at the posterior calf here in this example, and so the skin is the most echogenic thin layer that you see at the top of the screen. The next layer is the subcutaneous fat. So this can be variable in its thickness, and it kind of has sort of a marbleized look. There's some echogenic fascial lines there, but they're kind of irregular in their appearance. And then you see this echogenic line here. So this is what the fascia looks like. And this is what's separating the subcutaneous tissue from your first muscle group. The next muscle here is the gastrocnemius muscle, and you can see how the muscle fibers kind of travel together. They can be oblique or transverse or longitudinal, depending on how you have your probe oriented. And then again, when you go to the next muscle group, which is deeper, and here the soleus muscle, you're going to see that thick echogenic fascial plane again separating these muscles. You can see again that the fibers are kind of in a different orientation, so that lets you know that you're looking at a different muscle. And if you have any question at all, one thing you can do is just flex the joint that's below the area you're looking, and you should be able to see the muscle during dynamic imaging. So first I'm going to talk about muscular trauma. So there are three major mechanisms how trauma occurs to muscles: stretch, direct impact, or penetrating trauma. And the manifestations can include hematomas, muscular tears, fascial injury, and or muscle herniation. So first I want to speak about intramuscular hematomas. So these are very common. They're much more common than other pathologies such as a mass that would lead to bleeding or a hematoma. So for the most part, we can see these, know what they are, recommend clinical follow-up, and we don't have to worry about them in the long term. These are usually from trauma, but they can be from spontaneous causes, particularly in the setting of anticoagulation. And what may be happening is that there's a small amount of trauma, it just wasn't recognized in the history. But when you have a patient on anticoagulation, the amount of hematoma relative to the trauma that was present may be out of proportion, so you may see a larger hematoma than you would otherwise expect. Follow-up for hematomas in the muscle are not standardized, but they should resolve over a period of weeks. And if there's anything kind of funny about the hematoma, so it's much larger than you expect, but there's not anticoagulation, or it's persistent, expanding, or otherwise atypical, you do want to consider some sort of follow-up or possibly an MRI. So I'll just show you a few cases of intramuscular hematomas on ultrasound. So this was a small hematoma we see on ultrasound, and because the history was kind of uncertain, they got an MRI, confirmed the findings, so you can see the classic appearance of blood product on MRI, and there was some peripheral but no central enhancement. This was a gentleman who had a pretty classic trauma history. He was swinging a golf club and heard a pop and then had pain in his thigh. Here we see a pretty large fluid collection that's between the vastus lateralis and the vastus intermedius, so it is intramuscular. And this gentleman was on aspirin Plavix, so he probably had a small muscle tear. Sometimes it's hard to see the actual muscle fibers, which I'll talk about in my later slides, but he had a sizable hematoma, and this was likely larger than it normally would have been because of his underlying anticoagulation. So he was just clinically followed to resolution. This was a hematoma that was incidentally seen in a patient for a DVT study, and you can see this is a hematoma that's probably subacute, looking at its appearance, so it's got layering of the different parts of the fluid as the elements are settling out. And again, you can see sometimes the muscle gets really kind of stretched out, so you have to look for your landmarks, make sure you use a large enough field of view to see where you are and to see the extent of the pathology that you're trying to assess for. But here you can see that there's muscle on each side, so this is an intramuscular hematoma. In my practice, we have a lot of hemophilia patients that we take care of, so a benefit of that is that we get a lot of follow-up for these patients. So this was a patient that had a hematoma between the muscles, predominantly the gastrocnemius and the soleus in the calf, and you can see what it looks like at 5 days, pretty anechoic. And then it's a little smaller, a little bit more heterogeneous at 2 weeks, and then more contracted and heterogeneous at 6 weeks. So this is the evolution of what a hematoma should do. It should get smaller with time. And lastly, just another example of a chronic hematoma that's got a kind of retracted and more hyperechoic appearance. So moving on to specific types of injuries that can occur, and we see this really commonly in the lower extremity, which is why I wanted to focus on it. So a stretch type injury commonly occurs in the gastrocnemius soleus plantaris complex. So this would be where the soleus muscle is located. The plantaris muscle is high and is mostly tendon running down to join the Achilles, and then the gastrocnemius muscle is the most superficial muscle, and it joins the Achilles tendon much higher up. So because the gastrocnemius has got sort of fast twitch skeletal muscle fibers, it's used for quick action, and it also crosses 2 joints, it's prone to injury more than some of the other muscles in this group. So when we see pathology in the calf, so the classic name is tennis legs, so someone comes in doing some sort of activity and has acute pain or has a popping sensation in the calf. Most of the time, this is going to be a partial tear in the gastrocnemius, usually the medial head. You can also get damage to the aponeurosis of either the gastrocnemius or the soleus muscle. And lastly, you can get plantaris tendon rupture, but that's actually much less common, which is why I have it small down here. And the majority of the time, you're going to be looking at injury of the gastrocnemius muscle. So this is the classic appearance. So what you're seeing here is sort of mostly hematoma. You get this sort of disorganized appearance, loss of the normal fibular pattern that you expect to see in the rest of the muscle. If you scan carefully, you can sometimes see the free end of the fibers that are torn here, but the history is going to fit this presentation, and also you're going to be able to see that the entire muscle is not involved, so this is not a complete rupture of the muscle, it's just involving one small area. So if we compare this side to the normal side, we can see how we don't see that focal area of disorganization and hematoma. I think this kind of looks like a knot in a tree, and this appearance you'll see repeatedly with partial tears of the gastrocnemius. These injuries also like to happen at the area of the myotendinous junction. So as I mentioned, the gastrocnemius joins the Achilles and forms its myotendinous junction much higher up than the soleus muscle. So you want to look at this area, and this may be the area where the patient has pain. But these muscle fibers, as they attach here, could be injured and torn. And here we can see the normal side compared to the abnormal side, and there's some fluid here where we've lost a few of those fibers. You can also get an aponeurosis injury, and if you look at this cine clip, you can see that the echogenic fascial plane between the 2 muscles, the gastrocnemius and soleus, is interrupted here. And this explains how we have hematoma that's then kind of tracking between the 2 muscles. So otherwise, if you just had tears within the muscle, it shouldn't be able to kind of track in the intermuscular plane. But anytime you see this, it's probably because the aponeurosis has been involved. And this is just another example of an aponeurosis injury. Here it looks like the gastrocnemius and soleus have just been kind of peeled apart from each other. So another pattern that can occur. So plantaris tear is actually pretty uncommon. So management for these are pretty similar. If you have a partial gastrocnemius tear or a plantaris tear, you're going to do conservative management, but it's considered to be a slightly less serious injury, so there may be some utility in trying to tell the difference. But what happens a lot of times, you see hematoma even tracking between the muscle planes and are unable to see the plantaris tendon, and it's assumed that the plantaris is torn. Whereas most of the time it's really just that it's a gastrocnemius tear or aponeurosis tear. If you're able to see the actual plantaris tendon like we had in this case, it was actually disrupted, you could see the 2 ends, then you can confidently say that it's a plantaris tendon tear. But from a clinical standpoint, it's not very important. There is some other pathology you can see in the calf that can mimic these types of injuries that is important to be aware of. So here we see a fluid collection that looks very similar to the one I was showing you with the gastrocnemius tear and aponeurosis injury. The difference here, though, is the location of this fluid collection. So notice how this is not between the gastrocnemius and the soleus. This is between the subcutaneous tissues and the gastrocnemius. So it's more superficial, more posterior in its location than where we were seeing the hematoma with the gastrocnemius tear. And this is more likely to be related to a popliteal cyst that's ruptured and tracking down the calf. This is where this fluid is going to occur. So when you see this, you want to just scan more superiorly and see if you have a popliteal fluid collection and if it connects. It's much less common for bleeding from a gastrocnemius tear to go into that tissue plane. So the differential in part of the fluid collection seen in the calf and acute pain in the calf is a ruptured popliteal cyst. Here's another example. This is quite a large hematoma. Again, it's in that space between the gastrocnemius and the subcutaneous fat posteriorly. And if you look at the cine clip, you see the classic little C-shaped area in the popliteal fossa where we have the cyst, and this is contiguous with this heterogeneous fluid collection. Another really important thing to remember is that when patients come with acute calf pain, they may actually have a DVT, or that's part of the differential diagnosis. I see gastrocnemius tears on my DVT cases and vice versa. So think about that, particularly if you don't see any other muscle pathology. This was a patient who happened to have a thrombus in a gastrocnemius vein. So remember that any veins deep to the muscular fascia are going to be deep veins and are going to need treatment. And so this just happened to be within the gastrocnemius muscle itself. Moving on to direct or blunt trauma, I've had a couple of really interesting cases where ultrasound was useful in just kind of aiding the diagnosis. And this was a gentleman who had a bike accident and had direct impact of his thigh to a stop sign post. So his radiograph was pretty unremarkable, but he had a lot of pain and a lot of swelling in his anterior thigh, and with ultrasound we could very easily tell that he had extensive lacerations in the compartments in his anterior thigh, so the vastus intermedius and laterus particularly. And you can see fluid here, but on this dynamic image where we're putting some compression, it's not only just fluid, you can see that these muscle fibers are definitely disrupted from laceration. And here's a nice longitudinal view just showing where the normal muscle is located, and then you can see this disorganized appearance where we have hematoma and laceration. And then just one last cine clip, you can see that it's not going through the entire muscle, but this is a high-grade tear/laceration of the vastus lateralis. This patient didn't need any additional imaging, so they just managed him conservatively, but we didn't see that on the x-ray. We could have seen it on CT or MRI, but we felt confident about the diagnosis from the ultrasound. This is something that you may see, maybe not in the acute setting, but you may see it as a palpable mass, and this is a small herniation of the anterior tibialis muscle through the fascial layer. So this can be caused by trauma from a stretch type injury. The fascia is really tight on the anterior tibialis, and again, it might not be any pain, it might not have been something that was initially noticed, but if you have somebody come in with this palpable mass, particularly positional, it can be felt better in the standing position. You can see that just as the normal appearance of muscle, it's just kind of breaking through the outer aponeurosis and then going into the subcutaneous fat. And lastly, for penetrating trauma, you would see similar findings in the other types of trauma. But in addition, because of the break of the skin and the subcutaneous tissues, think about the possibility of gas, foreign bodies that you may see. You might see hematoma and fiber disruption, and then look for active hemorrhage on your color Doppler evaluations. Next, I want to talk about masses that you can see in the muscle. So primary masses in the muscle, particularly benign ones, are really not that common. There's one myxoma I want to speak about. And then really for primary malignancies of skeletal muscle, that would involve sarcomas. We can see a lot of other types of masses, either benign or malignant, that come from other tissue types that are within the muscle. So they are going to appear intramuscularly, and I'll show you some examples of that. Also, masses in the muscle may actually be originating or emanating from bone or cartilage, so deeper structure. So again, it's important to try to assess the whole area that you're scanning. You can get local recurrence of malignancies in patients that have already had surgery, metastases, and then mimics or pseudotumors. So unfortunately with ultrasound, we're not able to always be definitive when we see masses, but there are worrisome features you can think about. So anything that's increasing in size, heterogeneous, has a lot of vascularity, and is hypoechoic tends to be more on the worrisome side for malignancy. And I just think it's important with ultrasounds, especially if the patient's presenting to you for ultrasound for their first image, to try to get as much information as you can. So ultrasound may be really useful and may be the only way to prove that there's color flow in a lesion. And it's useful to just determine the location of where the mass is, and it's really great for biopsy guidance. So this is one of my favorite cases that started off with the MRI for another reason, so hip pain. And we saw this very round T2 bright mass in the upper thigh. They went on to PET-CT as the next imaging modality, and there was no activity in this mass. So there was uncertainty about whether this could be a hematoma or some other type of tumor that wasn't avid. So they then went to ultrasound, and here you can see this very round but heterogeneous mass, and with careful interrogation, we were able to show that there was flow within this mass. So we've got an arterial signal here. And also, if you notice, there's a lot of mass effect on the adjacent muscle, more than maybe you would expect for fluid collection. So this turned out to be a low-grade myxoma. And these tumors are a really major mimic for hematomas. I've seen more than one of these now, and you have to really be careful to use low power settings and low flow settings to look for color Doppler. But we were the modality that first was able to show that this was a mass, and we subsequently biopsied it, and then they had it removed. Other masses you can see in muscle, so this is an intramuscular hematoma, so these can have a variety of appearances, but usually more echogenic, and this was confirmed with MRI. This was a patient who'd had a prior vascular malformation, and you can see that there's this hypoechoic mass with some color Doppler flow, and again, to prove this, we got an MRI. This was very bright on T2. This was a patient with a history of neurofibromatosis, and you can see that there's this oblong, very well-marginated mass with very little color Doppler flow present. And if you correlate this with the MRI, it was T2 bright with enhancement. And given the history and given the multiplicity of masses that this patient had in other locations, this was confirmed by imaging alone to be a neurofibroma. This was a recent case I had in my institution, and as you can see, this is a very large heterogeneous mass with color Doppler flow. So the one thing that's nice about imaging primary muscle malignancies or sarcomas is they're usually not subtle at their primary presentation. So looking at this, you would be extremely suspicious for malignancy. And when we use our high field imaging or high frequency transducer, it's just nice to be able to see that this is actually within the muscle. So you can see the subcutaneous tissue, and then you see the muscle layer, and the mass is within it. And then we did an MRI, showed this large heterogeneous mass with enhancement, and this was a liposarcoma. It's important to remember that sarcomas, when they occur, they tend to go along the surgical plane or surgical margin. This was a patient who'd had multiple prior surgeries for sarcoma, and he was in our department for a DVT study, and one of my sonographers incidentally found this mass. So it's a pretty homogeneous mass. It does have color Doppler flow. We also got an MRI, just to look at its appearance, but this was right where he had had his prior surgery, and this was a recurrent myofibrosarcoma that we also subsequently biopsied with ultrasound. So local recurrence of sarcomas is common. Here's another example. Again, not subtle. You'd be able to see this nicely with ultrasound. Just remember that history is important, and in someone who's had a prior surgery for sarcoma, you would be very suspicious of this mass. And they can be less subtle, so this is a small nodule, it's hypoechoic, but it's deep, it's within the muscle. This isn't an area you would expect a lymph node to occur, so with this history, even this tiny area is suspicious. You can get muscle metastases, so melanoma is a malignancy that likes to go anywhere, particularly in the muscles. It has a very hypoechoic and vascular appearance. Here you can see it's just deep to the muscular fascia, kind of splaying apart the muscle fibers. And then this is showing it on the PET-CT with very strong avidity. Again, just want to emphasize the importance of looking at the characteristics of what you're seeing on your ultrasound to just try to get more information. So in this case, we're looking at two images where this area is predominantly fluid. You may think, is this an abscess, is this a hematoma, or some other process? But if you look very carefully where I have the arrows, there's this thin curvilinear areas of echogenicity. These are consistent with calcifications, and if you look at this non-contrast CT, you can see the same calcifications. So this is taking up the thigh musculature, but this was in a patient who'd had a history of a chondrosarcoma. So that was a recurrence, and that explains the calcifications. So this wasn't something that primarily came from the muscle, but was involving it, and this just gave us a clue about the type of tissue we were looking at. Similarly important to look at the whole field of view when you see a mass. So this was a large mass, definitely involving the space of the muscles in the thigh. But if you look at the deepest part of the image that I'm showing you, you can see the cortex of the bone is disrupted, and this mass is actually emanating from it. And this is shown really nicely on the MRI as well, post-contrast. So this was a large osseous metastasis from lung cancer that was originating in the bone and then involving the musculature secondarily. This was another case. I had this young female who had this large mass in her thigh. She also had diffuse enlargement of her thyroid gland. And we did a biopsy of this mass under ultrasound. And notice here how you can see that the musculature is actually pushed very far anterior, so it's thin. And this mass is appearing somewhat separate. And on the cine clip, the important finding here is that you can see that there's irregularity along this cortex of the femur. So that kind of shaggy line is very abnormal. And what was happening in this case is there was a break in the femur posterior on her leg, so an area we weren't imaging, but all of this mass was emanating from the medullary cavity of the bone, and it was just pushing the muscle anteriorly. And this was a lymphoma of osseous origin. Lastly, I want to talk about a couple of mass mimics. So if you see a focal mass in the muscle with a lot of calcification, and if you're lucky to have an X-ray to correlate it where you can see the calcification, this may be myositis ossificans. So to ensure this, you want to think about the patient history and then potentially do a follow-up, but you don't want to mistake this for a malignancy. Again, scar tissue can look very odd on ultrasound. This was in the gluteal region. We see this very heterogeneous mass, a lot of shadowing, so hard to actually see the characteristics of the mass. And this was biopsied because it wasn't certain what it was and because of its size, and this just turned out to be a rigorous amount of scar tissue. Lastly, I want to talk about diffuse or infiltrative processes you can see in the muscle. So first you can see atrophy, and so if you just compare one side to the other, in this case this was looking at the calf muscles, one is larger than the other. The muscle should look pretty normal in its configuration or morphology. Otherwise it can be increase in echogenicity, and this can be a unilateral process if it's something that is from disuse or other kind of trauma or even innervation, or you can see it more diffusely from systemic diseases or medications such as steroids. Another condition that we don't see commonly but is good to be aware of is transient muscular edema. So after overuse of a muscle, you can have delayed, it's called muscle soreness, so it usually peaks several days after activity. And if you look with ultrasound, you just see diffuse increased echogenicity of the muscle, and you would also see that on a T2 MRI. And this is a self-limited process that's just going to go away in a short period of time. So if there's any uncertainty, that's the way to ensure that you've made the right diagnosis. Infectious myositis doesn't usually occur in otherwise healthy persons, and it may require more intense therapy than cellulitis alone. So they may need to have surgical debridement, they may need to have IV antibiotics instead of just oral antibiotics. So it's important to recognize when your soft tissue infections have extended deep to involve the muscles. Also, you want to think about concurrent osteomyelitis or joint infections, and you may or may not be able to see that with your ultrasound, but think about looking for bone irregularity or joint effusions. And there can be a variety of appearances of myositis, and the history is also important. So this was a young female with precocious puberty who had a Lupron injection into the muscle. So you can see here, this looks really mass-like, this hypoechoic area with a lot of vascularity. This was homogeneously enhancing on the MRI, but with the history of having the injection there and her clinical findings, this was consistent with focal myositis. She was treated and this resolved over time. Again, this case is pretty clear that there's this fluid collection that's got some debris and layering, and this is definitely within the thigh muscle. So we've got the subcutaneous tissue, then we see our muscle fibers, and then here we see this abscess. This is the MRI correlate, so you can see the same abscess cavities here where there's no enhancement, but notice how extensive this is in the muscle, which we really didn't appreciate as much on the ultrasound. There's just intense enhancement throughout the muscle. So it's important to recognize this on ultrasound because, again, this is a really advanced infection and this patient may need more aggressive therapy. Just another example of an abscess, how it can look kind of mass-like, especially early on. We see just a hypoechoic area with vascularity, and then if you look at the CT scan, clearly we have this thick rim of enhancement with some more central fluid component. Moving on to a different process. This was a older gentleman who came into the hospital for other reasons and had very acute onset of pain and swelling in his calf on the right side. And I love showing this case to my sonographers because they almost always think right away that it's a fluid collection. But if you look carefully at this cine clip, you can see that we've got all of this echogenic like architecture within this, and this is actually just the gastrocnemius muscle, so it's not a fluid collection, it's the muscle that's just markedly expanded and hypoechoic. So if we compare this to the other side, this was the medial belly of the gastrocnemius. This muscle is enlarged and hypoechoic, and this was most consistent with muscle infarction given his history. And last case I want to show you is in a patient who had a known history of lymphoma. He had a CT scan that showed some increased density and some extra kind of soft tissue in the posterior gluteal region, so this was actually the piriformis muscle. They were worried about potentially hematoma in this location, but they got an ultrasound and you can see that this is a very hypoechoic appearance of the whole piriformis with a lot of color vascular flow. So this was not a hematoma, this was diffuse involvement of the piriformis with lymphoma, and then we were able to do a biopsy to confirm that. So much easier to tell the difference using ultrasound in this case. So in conclusion, muscle pathology is common in the lower extremity and in other muscles, and I think it's something that's not always, talked about or easy to kind of get answers regarding. It can be most commonly trauma, lots of different types of masses, or also infiltrative diffuse processes. It's helpful to be aware of pseudotumors and other mimics, so if you know classic appearances of some of the pathology, such as trauma, or some of the benign masses, it'll help you to kind of form your differential diagnosis. Be really careful with the Doppler evaluation, especially for those low flow tumors that I showed that can look like fluid collections. And if there's any uncertainty, we can't always get the exact answer with ultrasound. Have a low threshold for follow-up or other imaging if you're unsure. Thank you very much.